Okay, so starting again from the question number 110, that what is more characteristically associated with nephrolithiasis and antiretroviral drug, indinavir. So indinavir is a protease inhibitor and is characteristically associated with nephrolithiasis. This is because that indinavir has poor solubility in urine and can precipitate to form crystals, which can form the kidney stone formation. Okay. Why not zidovudine? Why not didanosine? Why not ritonavir? Why not nevirapine? Okay, for that we have to read all this stuff. Antiretroviral therapy involves a combination of at least 3 drugs, typically 2 NRDI and either a PI or an NRDI. What is NRDI? Nucleoside reverse transcriptase inhibitor. PI protease inhibitor, and NNRDI is non-nucleoside reverse transcriptase inhibitor. So this combination both decreases viral replication but also reduces the risk of viral resistance emergence. So there are two things which are happening. The viral replication is decreasing and the viral resistance is emerging. So following the 2015 guidelines, it is now recommended that start antiretroviral therapy as soon as they have been diagnosed with HIV rather than waiting for a particular CD4 counts. Okay, because after the CD4 count, it is confirmed that what is the viral load of HIV. So we are not gonna wait of the CD4 count. We will be starting antiretroviral therapy as soon as the patient is diagnosed with the HIV. So what will be the entry inhibitors? Maraviroc and enfuvirtide. Okay, so how we can remember this? That Mara, we will remember them by changing their names. Okay, so and how we can do this? That Maraviroc is binds to CCR5, preventing interaction with GP41. But Enfu, I will all remember the first name. Mara binds to CCR5 and prevents interaction with GP41, but Info binds with GP41, also known as fusion inhibitor. Okay, remember, Mara inhibit the interaction with preventing an interaction with GP41, but Info binds to GP41. Okay, so next is that it also prevents HIV-1 from entering and infecting immune cells. Next, so NRTIs. What are the NRTIs? Zidovudine, abacavir, emtricitabine, didanosine, lemuvudine, stavudine. It is not important for you to remember all the names, but it is very important for you to at least remember the side effects which they are causing. Okay, just remember, just read 2 to 3 times the names of examples. And general side effect is peripheral neuropathy. Okay, peripheral neuropathy. Tenofovir used in 2 recommended regimes: adverse events in renal impairment and osteoporosis. Okay, so it is mainly the renal impairment and osteoporosis. Too many O's, osteoporosis. Okay, and VIR, RI, renal impairment. Renal impairment. I, impairment. R, renal impairment. O, osteoporosis. Zidovudine, you can remember, is like that MAB or BAM. ZBAM, like Jhandu balm, Jhandu Jhandu for zidovudine, balm, black nails, anemia, myopathy. Didanosine, pancreatitis. Okay, DP. NRTI, nevirapine and efavirenz. Remember that nevirapine has side effect that this interaction of P450 enzyme. Okay, and nevirapine induces it, P450, and also causes the rash. Protease inhibitors. Indinavir, remember it is vir, or we can say navir. Indinavir, nelfinavir, ritonavir, sequinavir, they're all protease inhibitors. And what are the side effects? Diabetes, hyperlipidemia, buffalo hump, central obesity. Doesn't it look like more like Cushing's side effects? Like Cushing syndrome. I'm not saying it is, but like we can remember it in that way. Okay, and the navirs are P450 enzyme inhibitors. Indinavir, okay, renal stone. RMCQ. Ritonavir, a potent inhibitor of P450 system. So these are the protease inhibitors. Remember, Indonever has the side effect of like renal stones, and Ritonavir has a potent inhibitor of P450 symptom. P450 system, yeah. Next is integrase inhibitors. So intig, remember all the examples have TIG, T-E-G, intig, raltegravir, elvitegravir, dolutegravir, okay, and they block the action of integrase, a viral enzyme that inserts the viral genome into the DNA of host cell. Remember that this line exactly sometimes come into the exam. Repetitive, it is more like a recall or repetitive exam MCQ, that a viral enzyme integrase, because okay, what integrase, what is the function of integrase inhibitors? That they block the action of integrase. What is integrase? A viral enzyme that inserts the viral genome into the DNA of the host cell. Remember, into the DNA of the host cell, not the RNA, not into the recipient cell, into the DNA of the host cell, and insert the genome. Each word is important. Question number 111. What is the mechanism of action of antiretroviral amantadine? What is amantadine? Okay. It inhibits uncoating of virus in cell, also releases dopamine from nerve endings. So number 1 is dopamine release and inhibits uncoating M2 protein of virus in cell. So what are the antiviral agents? Acyclovir. Remember that acyclovir and ganciclovir both are guanosine analog, phosphorylated by TK, thymidine kinase TK, which in turn inhibits the viral DNA polymerase, both of them C. Okay, and the ribavirin is also guanosine analog. It inhibits IMP dehydrogenase, interferes with capping of viral mRNA. Okay, so remember that acyclovir and ganciclovir are guanosine analog, inhibit and phosphorylated by TK, tyrosine kinase, and inhibit the viral DNA polymerase, and ribavirin inhibits IMP dehydrogenase and interferes with capping of viral mRNA. Amantadine inhibits uncoating M. Okay, and also releases dopamine from nerve endings. Oseltamivir inhibits neuraminidase. It is very important MCQ, and it is its indication is influenza. Okay, foscarnet. What is foscarnet 2? Pyrophosphate analog, which inhibits viral DNA polymerase. It is a pyrophosphate analog. All the first three, guanosine, acyclovir, ganciclovir, and ribavirin, are guanosine analogs. It is a pyrophosphate analog. PF or FP, whatever, in which way you want to remember it. Interferon alpha, human glycoprotein, which inhibits synthesis of mRNA. So remember that interferon alpha is involved in the inhibition of synthesis of mRNA, and ribavirin is interfering the capping of viral mRNA, messenger RNA. Okay, cidofovir is acyclic nucleoside phosphate and is therefore independent of phosphorylation by viral enzymes, and we can do it back. Okay, so remember, okay, back to acyclovir HV, herpes simplex, varicella zoster, ganciclovir GC, CMV, ribavirin hepatitis C, chronic RSV like respiratory syncytial virus, amantadine influenza and Parkinson. And remember, oseltamivir inhibits neuraminidase, influenza, foscarnet, pyrophosphate analog. Okay, and again CMV and HSV. Interferon alpha in chronic hepatitis B and hairy cell B and C, hairy cell leukemia. Okay, ribavirin was only C and RSV. Cidofovir, it is important, CMV retinitis. Okay, cytomegalovirus retinitis in HIV. Now move to the adverse effects. So it is, when it is acyclovir, remember it is mainly the crystalline nephropathy. Okay, crystalline nephropathy, Gansi, myelosuppression, agranulocytosis. You have to remember this and cram it somehow. Ribavirin is for hemolytic anemia. So acyclovir is for crystalline nephropathy, Okay, and the gansecyclovir is myelosuppression, granulocytosis, agranulocytosis, ribavirin, hemolytic anemia, amantadine, confusion, ataxia, slurred speech, phosphocarnate, new nephrotoxicity, hypocalcemia, hypomagnesemia. Remember, amantadine, A for amantadine, A for ataxia. Phosphocarnate, it is important for you to remember. Calcium will be low in blood, magnesium will be low in blood. Interferon alpha is also causing myelosuppression. There was one more which was causing myelosuppression. What was that? Gansecyclovir. So gansecyclovir and interferon alpha, both of them are causing the myelosuppression. So cidofovir is also having the nephrotoxicity. Phosphocarnate and cidofovir. Next is antiretroviral agents in the HIV. Okay, we have already read them. Move ahead. Question number 112. A 27-year-old woman presents with a headache and tremor affecting her right arm. She has just returned from a trip visiting family in rural India. On examination, there is a fever of 38.5 degrees Celsius and multiple mosquito bites on the arms. On neurological examination, the cranial nerves are all intact. There is increased tone on the right wheel with cogwheel rigidity in the right upper limb, and 5 Hz tremor affecting her right arm. All the reflexes, power, sensation. Which area of the brain is inflamed? They say that the basal ganglia is inflamed. Okay. The way they are predicting it, they are showing us the symptoms are showing that the patient is having the INCAF with Parkinsonism. Okay, the tremors and the cogwheel rigidity. Okay. So why basal ganglia? So the patient is showing the classic tremor and rigidity of Parkinsonism, the cogwheel, of course. The unifying diagnosis in this case is one of the Japanese encephalitis, which can present with Parkinsonism when the basal ganglia is involved. Clues pointing to this in the stem include fever, mosquito bites. Okay, Japanese encephalitis is transmitted via mosquito vector. Okay, so there are mosquito bites and the fever. So they are pointing towards the Japanese INCAF. Why not cerebellum? Because cerebellum mostly associated with the balance, that is stridokinasia, the nystagmus, and the tension tremors of all right. Okay. Next is a frontal lobe. Frontal lobe is mainly towards because it is inflammation of area, personality changes, the stuff. Parietal is mainly associated with sensory impairment and apraxia, and the temporal lobe is associated with mostly found in inflammation in the lobe, in herpes simplex and calf. So what is Japanese encephalitis? It's a high yield, it's a star. Japanese encephalitis is the most common cause of viral in calf. Okay, and it is a flavivirus transmitted by Culex mosquito. Remember, Culex mosquito, Japanese in calf by Culex mosquito, which breeds in rice paddy fields. Remember a Japanese boy playing in the rice paddy fields, and he has a pet. His name is Culex. Okay, and he also playing with flowers. Okay, so that's how we can make a picture in our mind, that Japanese boy playing in rice paddy fields, playing with flowers. By flowers we can remember the flavivirus, and he has a pet mosquito which is Culex. Okay, the reservoir hosts are aquatic birds, but pigs are an amplification host, and therefore close domestic contact with pigs is a risk factor. So contact with pigs is a risk factor. The clinical features are headache, fever, seizures, confusion, and pancreatic features include basal ganglia involvement. It can also present with acute AFP, okay, acute flaccid paralysis. Diagnosis is by serology and PCR. Management is supportive. Remember, imagine studying a lot about a disease, and at the end management is supportive. Oh my god. Prevention is a vaccine, and there are a variety of different types. Okay, so a 33-year-old man is admitted due to profuse diarrhea. He has a history of HIV infection and cryptosporidium diarrhea. Cryptosporidium. Remember. Which investigation is most likely? We have read it before, that the most likely and most important investigation is always the stool sample. Which stool sample? PCR or the acid fast? Acid fast. Okay, why? Because the cyst will turn red following acid fast staining, and it is the most important investigation to confirm the diagnosis. Okay, so diarrhea is common in patients with HIV, and this may be due to the effects of virus itself or opportunistic infections. Possible cause is Cryptosporidium or plus other protozoa, but here they mention that it is Cryptosporidium. CMV, Mycobacterium avium intracellular giardia. Cryptosporidium is the most common infective cause of diarrhea in HIV patients. It is an intracellular protozoa and has incubation period of 7 days. Presentation is very variable, ranging from like mild to severe diarrhea. Remember, Zeal-Nielsen stain or acid fast like Zedin staining shows the red cyst of Cryptosporidium, and treatment is difficult. Mycobacterium avium intracellular is an atypical microbacteria seen with CD4 count is below 50. Okay, typical features are the same: fever, sweats. Remember, sweats is a bit different here. Abdominal pain, diarrhea. There may be hepatomegaly, deranged LFTs, and diagnosis is made by blood cultures and bone marrow. What will be the management? Rifabutin, ethambutol, and clarithromycin. Nitazoxanide is licensed in US for immunocompetent patients. Remember that for Mycobacterium avium, it is rifabutin, ethambutol, and clarithromycin. Okay. Next, a 24-year-old heterosexual man presents to the GUM with a history of dysuria, urethral irritation, and milky discharge from the urethra. Urethral microscopy reveals more than 10 polynuclear lymphocytes per field, but no gonorrhea is seen, and urine dip is normal. He did a home test 3 days ago when his symptoms started, and chlamydia and gonorrhea are negative. Remember, chlamydia and gonorrhea are negative. Urine dipstick normal. Last sexual encounter was 3 weeks ago. What will be the diagnosis? Okay. Not non-specific. I hope now it is better focus. Okay. Non-specific urethritis is a common presentation where inflammatory cells but no gonorrheal bacteria are seen on swab. It requires treatment with doxycycline and azithromycin. So we will start treatment. Doxycycline for 1 week. The presence of pus cells on urethral swab suggests a diagnosis of non-specific urethritis, which commonly presents with symptoms similar to these. Okay, so the guidelines recommended oral doxycycline. The window period for chlamydia and gonorrhea is generally 2 weeks, so the home test he did is likely to be accurate, while retesting may be appropriate and not good. Okay, next. Non-gonococcal urethritis, sometimes referred to as non-specific urethritis, is a term used to describe the presence of urethritis when a gonococcal bacteria are not identifiable or the initial swab. The typical case would be a male who presented to a GUM clinic with a purulent urethral discharge and dysuria.